There is a moment that many people over 65 described to me when they first noticed that something had changed. Maybe it was stepping off a curb and feeling momentarily uncertain in a way they never used to. Maybe it was reaching up to a high shelf and feeling a brief sensation of tipping that made them grab the counter. Maybe it was walking on uneven ground, a gravel path, a grassy lawn, a cobbled street, and realizing they were watching their feet far more carefully than they ever used to. Or maybe it was someone else who noticed first, a family member who said, "You seem a little unsteady," or a doctor who mentioned, "We should talk about your balance." And however that moment came, it brought with it a question that I want to answer today. Is this just aging, or is something else going on? Because that question matters more than most people realize. Because the answer is not always, it is just aging. And when the answer is something else, something specific, something treatable, not knowing that means living with a problem. That did not have to continue. I am Dr. Daniel Chen, and today I want to explain how balance actually works, what genuinely changes with age, and what changes in balance are not simply inevitable, but are signs of specific conditions that deserve evaluation and treatment. So let us start with how balance works, because most people have never been given a proper explanation of this. And once you understand it, the rest of this makes much more sense. Balance is not a single sense. It is not simply a matter of being steady on your feet. It is a complex and continuous process that your brain manages. Every moment you are upright and moving, using information from three completely separate sensory systems simultaneously. The first system is your vision. Your eyes provide continuous information about where you are in space relative to the world around you, about the position of the horizon, about whether you are moving or whether the world around you is moving, and about the features of the surface you are walking on, steps, uneven ground, slopes. Vision is the most powerful of the three balanced sensory systems. When vision is clear and available, it dominates the balance equation. The second system is your vestibular system. This is the balance organ of the inner ear. Each inner ear contains three semicircular canals and two additional structures called the utricle and saccule. Together they detect rotational movement of the head, linear acceleration, and the pull of gravity. They tell your brain how your head is oriented in three-dimensional space and how it is moving. The vestibular system is particularly important during fast movements, head turns, changes in direction, and in situations where vision is absent or unreliable, like walking in a dark room, or on uneven ground where the visual scene is not providing clear balance information. The third system is proprioception. Proprioception is the sense of where your body parts are in space without looking at them. It comes from specialized receptors in the muscles, tendons, and joints throughout your body, but particularly in your feet and ankles, your lower legs, and your spine. These receptors continuously send information to your brain about how much the muscles are contracted, how much the joints are bent, and how the body's weight is distributed across the feet. Proprioception tells your brain where your body is and how it is positioned at every moment, even when your eyes are closed and your head is still. Now here is how your brain uses these three systems. Your brain continuously receives information from all three and cross-references them against each other to construct a coherent picture of where you are in space and how you are moving. When all three systems are providing clear and consistent information, balance is maintained without conscious effort, without thinking about it, without watching your feet. But when one or more of these systems is providing degraded information due to aging, disease, injury, or other causes, your brain has to work harder with less reliable input, and balance becomes more effortful, more conscious, more dependent on compensatory strategies like watching your feet or reaching for support or slowing down. Now let us talk about what genuinely changes with age. In each of these three systems, starting with vision after 65, several visual changes occur that are relevant to balance. Visual acuity, the sharpness of what you see, tends to decline, particularly with age-related conditions like cataracts, macular degeneration, and glaucoma. Contrast sensitivity, the ability to distinguish objects from their backgrounds when the color difference is subtle also declines, and contrast sensitivity is particularly important for balance because it is what allows you to detect the edge of a step, the boundary between a rug and a floor, or a curb at the edge of a road. When contrast sensitivity is reduced, these hazards become harder to detect before they cause a stumble. Depth perception, the ability to judge distances accurately, also changes with age and is particularly relevant to safely navigating stairs and uneven surfaces. The rate of visual processing, the speed at which the brain can interpret what the eyes are seeing, also slows somewhat with age, meaning visual information arrives at the balance centers of the brain a little more slowly than it did at 40. Now moving to the vestibular system, the hair cells inside the semicircular canals and the otolith organs that detect movement and gravity gradually decline in number with age. Research has shown that by the age of 70, a significant proportion of the hair cells of the vestibular system may have been lost compared to younger adults. This means that the vestibular signal sent to the brain is less precise, less sensitive, and less reliable, particularly for detecting slow movements and subtle changes in head position, and the nerve fibers that carry vestibular signals from the inner ear to the brain also lose some of their conduction speed with age, meaning the signal arrives at the brain a little more slowly than it once did. In the third system, proprioception, age-related changes in the receptors, in the muscles, joints, and skin reduce the precision and sensitivity of proprioceptive information, particularly in the feet and ankles, which are the most important proprioceptive sources for upright balance. This reduction in foot and ankle proprioception is significantly worsened by peripheral neuropathy, which is itself more common after 70, as I have discussed in a previous video, and the muscles themselves, particularly the postural muscles of the lower leg and core that respond to balance perturbations, lose some of their speed of response with age. In younger adults, when balance is disturbed, the corrective muscle responses in the ankles, hips, and trunk happen extremely quickly, within milliseconds. In older adults, these responses are slower, less powerful, and less well coordinated, which means that the window between a balance disturbance and a fall is narrower. Recovery from a stumble is harder and more likely to result in a fall. Now, all of these age-related changes are genuine. They are well documented, and they explain why balance becomes somewhat more challenging after 65 and why falls become more common. This is normal aging of the balance system, and it is something that exercise, particularly balance-focused exercise, and exercise that maintains muscle strength, can meaningfully slow and partially compensate for. But here is where I need to be equally clear about what is not normal aging and what deserves evaluation. There are several conditions that cause balance problems in adults over 65 that are not simply the inevitable consequence of getting older, that have specific causes that are diagnosable and that are often treatable, or at least significantly manageable with appropriate intervention. The first condition is benign paroxysmal positional vertigo, or BPV. This is one of the most common vestibular disorders in adults over 65, and one of the most frequently under-recognized and undertreated. In BPV, small calcium carbonate crystals called otoconia that normally sit on the otolith organs of the inner ear become dislodged and fall into one of the semicircular canals. When this happens, the crystals move abnormally within the canal when the head is moved in specific ways. This abnormal movement of the crystals creates a false signal in the vestibular system that tells the brain the head is spinning when it is not. The result is a sudden intense sensation of vertigo, the world spinning violently, that typically lasts from seconds to about a minute and is triggered specifically by certain head movements, rolling over in bed, looking up, bending forward, or tilting the head to one side. BPPV is more common after 65 for several reasons. The otoconia can become fragile with age and more prone to dislodging, and any head injury, ear infection, or a prolonged period of inactivity can trigger the problem. The reason BPV matters so much in the context of balance and falls is that the sudden unexpected vertigo it causes can trigger a fall in people who do not know what is happening and who are not prepared for that sudden sensation. But the reason BPV is so important in the context of treatable causes of balance problems is that it is remarkably treatable. BPV is treated with a specific repositioning maneuver called the Epley maneuver, or one of several related procedures in which the doctor or physiotherapist guides the patient's head through a specific sequence of positions that moves the displaced crystals out of the semicircular canal and back to where they belong. This maneuver, when performed correctly by a trained clinician, resolves BPPV in the majority of patients, often in a single session, sometimes requiring 2 or 3 sessions. The resolution is often rapid, and the impact on the patient's quality of life, balance, and fall risk can be immediate and dramatic, yet many adults over 65 with classic BPPV symptoms have never been assessed for it, have never had the Epley maneuver performed, and continue to live with vertigo and an elevated fall risk that could have been addressed in a single clinical appointment if you experience sudden intense spinning vertigo triggered by specific head movements, rolling over in bed, looking up, or bending forward. Please ask your doctor whether you should be assessed for BPPV. It is a simple clinical assessment that can be done in a standard appointment, and that could resolve a problem that may have been affecting your life for months or years. The second condition is vestibular neuritis or labyrinthitis. These are conditions in which the vestibular nerve, or the inner ear itself, becomes inflamed, often following a viral infection. Vestibular neuritis causes a sudden onset of intense vertigo that is persistent rather than triggered by specific movements. It can last for days to weeks in its acute phase and may leave some degree of residual balance impairment even after the acute phase resolves. This residual impairment is often described as a persistent sense of unsteadiness or dizziness with movement rather than the spinning vertigo of the acute phase. Vestibular neuritis and labyrinthitis are treated acutely with medications to reduce the vertigo and nausea, and subsequently with vestibular rehabilitation, a specific form of physical therapy that uses targeted exercises to help the brain compensate for the damaged vestibular input by recalibrating how it uses information from the remaining functional vestibular system and from the other balanced sensory systems. Vestibular rehabilitation has strong clinical evidence for improving balance, reducing dizziness, and reducing fall risk in patients with vestibular disorders. The third condition is Meniere's disease. Meniere's disease is a disorder of the inner ear characterized by episodes of intense vertigo that last from 20 minutes to several hours, combined with fluctuating hearing loss, a feeling of fullness in the ear, and tinnitus, a ringing or roaring sound in the affected ear. Meniere's disease is less common than BPPV or vestibular neuritis, but it is a specific diagnosable condition with a range of management options, including dietary modifications, particularly sodium restriction, diuretic medications, and in more severe cases, procedural interventions that can meaningfully reduce the frequency and severity of episodes and the associated impact on balance and quality of life. The fourth condition is medication-induced balance problems. I have discussed this in the context of falls more broadly in a previous video, but I want to highlight it again here because it is one of the most common and most correctable causes of balance deterioration in older adults. Several classes of commonly prescribed medications in adults over 65 directly impair the balance system. Aminoglycoside antibiotics can cause permanent damage to the hair cells of the vestibular system, making this a particularly serious concern. Anticonvulsant medications, including phenytoin, can impair cerebellar function and balance. Certain blood pressure medications, causing orthostatic hypotension, as discussed, benzodiazepines and sedating medications, which impair central processing of balance information, and some loop diuretics at high doses can cause vestibular toxicity. A medication review, specifically considering the effect of current medications on the vestibular system and on balance, is an important component of evaluating balance deterioration in older adults. The fifth condition is cervicogenic dizziness. This is dizziness and balance problems that originate from the cervical spine, the neck, rather than from the inner ear or the brain. The cervical spine, particularly the upper cervical region, contains a dense array of proprioceptive receptors that contribute significantly to the brain's sense of head position and orientation. When the cervical spine has significant arthritis or muscle tightness, or when it has been injured, these receptors can provide abnormal signals that conflict with the signals from the vestibular system and contribute to a sense of dizziness, unsteadiness, or difficulty with head movements. Cervicogenic dizziness is diagnosed clinically by a physiotherapist or doctor with expertise in vestibular conditions, and it responds to manual therapy and targeted exercise to address the cervical spine dysfunction, rather than to vestibular rehabilitation alone. The sixth condition is central causes, including cerebellar atrophy and small vessel cerebrovascular disease. The cerebellum is the part of the brain most directly responsible for coordinating movement and fine-tuning balance. Small vessel cerebrovascular disease, which involves tiny areas of damage in the deep white matter of the brain, often related to long-standing high blood pressure or diabetes, can affect the pathways that carry balance signals through the brain and can cause a characteristic pattern of unsteadiness that is often described as walking on a boat or feeling that the floor is moving. These central causes are identified through clinical assessment and brain imaging and are managed through treatment of the underlying vascular risk factors alongside vestibular rehabilitation and careful fall prevention. Now let me explain what an appropriate evaluation of balance problems in an older adult should look like, because I want you to know what to ask for and what to expect. A thorough balance assessment goes well beyond asking whether you feel steady. It includes a detailed history of when the balance problem started, whether it came on suddenly or gradually, whether it is constant or episodic, whether it is triggered by specific movements or present at rest, whether it is accompanied by vertigo, hearing changes, tinnitus, or ear fullness, whether it is worse in the dark or on uneven surfaces, and what medications you are taking. A clinical vestibular examination, including specific tests for the three balance systems. Vision assessment, the Romberg test, which assesses balance with eyes open and eyes closed, the head impulse test, which specifically assesses vestibular function, the Dix-Hall-Pike test, which tests for BPPV, and gait assessment, including the tests I described in the fall risk assessment video. Hearing assessment, since vestibular and auditory function are closely linked in the inner ear. And when indicated, brain imaging to assess for central causes. This evaluation may involve your primary care doctor, an ear, nose, and throat specialist, an audiologist, a neurologist, or a physiotherapist, specializing in vestibular rehabilitation, depending on what the initial assessment reveals. If you are experiencing balance problems that have been dismissed as simply aging without a thorough clinical evaluation, I want to encourage you to ask for one. You can say, I have been having balance problems that are affecting my confidence and my daily life. I would like a thorough assessment to determine whether there is a specific cause that could be treated. That is a completely reasonable request, and one that any doctor should take seriously, because while some balance change is a genuine part of aging, a significant portion of balance problems in adults over 65 have specific and addressable causes that should not simply be attributed to age and left unaddressed. Let me bring everything together for you now. Balance depends on three sensory systems: vision, the vestibular system, and proprioception. All three experience genuine age-related changes after 65 that make balance somewhat more challenging and falls more likely. These changes are real, and exercise, particularly balance and strength training, can meaningfully compensate for them. But several conditions are common in adults over 65 and cause balance problems that are not simply aging, including BPPV, which is caused by displaced inner ear crystals and is highly treatable with the Epley maneuver. vestibular neuritis, and labyrinthitis, which respond to vestibular rehabilitation, Meniere's disease, which has specific management options, medication-induced balance problems, which are addressed through medication review, cervicogenic dizziness, which responds to physiotherapy, and central causes, including small vessel cerebrovascular disease, which is managed through vascular risk factor control. If your balance has changed, and you have been told it is just aging, without a thorough evaluation, please ask for one. Tell your doctor what you are experiencing, ask whether there could be a specific cause, and ask whether you should be referred for vestibular assessment or vestibular rehabilitation. You deserve to know whether what you are experiencing is something that can be helped, because in many cases, it can. I am Dr. Daniel Chen. If this video helped you understand that your balance changes may deserve more than reassurance, please share it with someone over 65 who has also been told it is just aging and accepted that answer when they should not have had to. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me what your balance changes feel like and whether you have had a thorough evaluation or whether you have been told it is just part of getting older. I read every single comment and I genuinely look forward to hearing from you. Take care of yourself. Your balance matters. Your steadiness matters. Your confidence in your own body matters. And you deserve answers, not just reassurance.